Hi everybody, and welcome to our module on hemolysis basics. In this module we're going to talk about some basic principles of hemolysis. In other modules I will talk about specific causes, but there are certain underlying features that apply to most of the hemolytic disorders. So hemolysis means the destruction of red blood cells by one mechanism or another, and this will cause a normocytic anemia, and that should be fairly easy to understand. If you have a collection of red cells and you begin to destroy a select number of them, you will get fewer red cells, meaning you will have an anemia, but the red cells won't be changed in size, so therefore it will be a normocytic anemia. So a normocytic anemia has an MCV of about 80 to 100, and there are two general mechanisms by which you can develop a normocytic anemia. The first is underproduction by the bone marrow. These are called non-hemolytic anemias, and there are a number of reasons why the bone marrow can underproduce red cells, and I talk about all of these in other modules. In this module, we'll focus on the hemolytic causes of a normocytic anemia. These are all situations where you have increased destruction of red cells by one mechanism or another. One common way to categorize the hemolytic anemias, in a way that you will see in many textbooks, is to lump them into those that are extrinsic versus intrinsic. So what do we mean by this? So a hemolytic anemia with an extrinsic cause is caused by something outside or extrinsic to the red cell, and there are generally three things that do this. This can be caused by antibodies. It can occur due to mechanical trauma, for example if the red cells have to traverse very narrow blood vessels, or it can be caused by something that infects the red cell. This is an external cause. It's a pathogen that has gotten inside the red blood cell, caused an infection, and that has led to hemolysis. Intrinsic causes, on the other hand, of hemolytic anemia are causes that are due to something intrinsic to the red blood cells. In other words, something that is a normal part of the red cell that is failing to do its job. And this generally happens when there's failure of either the membrane, the hemoglobin, or an important enzyme. So for example, hereditary spherocytosis is the classic membrane-caused hemolytic anemia. A G6PD deficiency is the classic hemolytic anemia due to an enzyme deficiency. And then in many hemoglobinopathies, including sickle cell anemia, there is abnormal hemoglobin, and this leads to hemolysis. And those are all intrinsic causes of hemolytic anemia. So if we go back to our breakdown slide of normocytic anemias, we can now group the hemolytic anemias into those with an intrinsic cause versus those with an extrinsic cause. And I have separate modules on both of these two types of hemolytic anemia. So I told you before that hemolysis leads to a normocytic anemia, and a normocytic anemia is one of the hallmarks of hemolysis. Now let's talk about some of the other hallmarks of hemolysis in terms of lab findings and clinical symptoms. And another hallmark of hemolysis is an elevated plasma level of LDH. LDH is lactate dehydrogenase. If you've watched the biochemistry module on glycolysis, you know that it is a glycolysis enzyme. It converts pyruvate into lactate. Shown on the screen is the terminal portion of glycolysis where phosphoenolpyruvate is converted to pyruvate. Now many cells will convert pyruvate into acetyl-CoA, which will enter the TCA cycle, which will then generate energy using oxidative phosphorylation. But red blood cells lack mitochondria, so they cannot perform oxidative phosphorylation. So they convert lots of pyruvate into lactate. This means that they have lots of LDH inside of the cells, and this will spill out of red blood cells when there is hemolysis, and this will generate a high plasma level of LDH in the setting of hemolysis. Another hallmark of hemolysis is an increased number of reticulocytes seen in the peripheral blood. Reticulocytes are immature red blood cells. Usually they constitute about 1 to 2% of the red cells in the peripheral blood. However, an increased reticulocyte count will be seen in hemolysis, and in fact it's a hallmark of hemolysis. We'll talk in a minute about how you can use the reticulocyte count to distinguish hemolytic anemia from other causes of normocytic anemia. But just so you understand how this happens, when there's hemolysis, an anemia develops. This leads to increased EPO production from the kidneys, and that stimulates the production of reticulocytes in the bone marrow. Some of them will spill out into the plasma, and you will see an increased reticulocyte count in the peripheral blood smear. So an increase in the reticulocyte count seen in the peripheral blood is a normal bone marrow response to anemia. This makes the reticulocyte count a very useful blood test in normocytic anemias. Like I told you before, normocytic anemias may occur due to underproduction by the bone marrow or increased destruction from hemolysis, and the reticulocyte count differentiates between these two causes. A normocytic anemia with a low reticulocyte count means underproduction by the marrow. A normocytic anemia with a high reticulocyte count means increased destruction, such as you can see in hemolysis. If we go back to this slide showing the two general causes of normocytic anemia, all of these over here, the non-hemolytic anemias, will have a low reticulocyte count. All of these causes over here, the hemolytic anemias, will have a high reticulocyte count. Now, it would be nice if you could just look at the reticulocyte count and decide whether it's increased or decreased, and then decide whether a normocytic anemia was due to underproduction or hemolysis. But it's not so simple, and that's because the reticulocyte count is reported as a percentage. So under normal circumstances, reticulocytes account for 1 to 2% of the red cells in the peripheral blood. In the setting of anemia, that percentage can rise to 4 to 5%. But to determine whether or not the bone marrow is responding appropriately, you need to correct that percentage for the degree of anemia. Let me explain. Let's look at these numbers on the bottom of the screen. So imagine a patient has a normal hematocrit of 45 and a normal reticulocyte count of 1%. Now imagine that patient develops a marked anemia with a hematocrit of 11. Well, the reticulocyte count will rise simply by virtue of the fact that there are fewer red cells. In other words, even if the bone marrow doesn't produce any more reticulocytes, the reticulocyte percentage will go up because there are fewer red cells. So what you need to do in order to determine whether the bone marrow response is appropriate is you need to correct the reticulocyte count. So in order to correct the reticulocyte count, you take the percentage, 8% in this example, and you multiply by the anemic hematocrit divided by a normal hematocrit, so 11 divided by 45. This gives you a reticulocyte count that is corrected to 2%, and this is very low. This is an inadequate bone marrow response. So even though the reticulocyte count increased to 8%, that was not sufficient, and the bone marrow is not responding appropriately. In other words, for a hematocrit of 11, you should have a very, very high reticulocyte count, and a reticulocyte count of 8% is not really that high. And I've summarized this right here. If the corrected reticulocyte count is less than 2%, this suggests inadequate bone marrow response to the degree of anemia. Sometimes you will see the reticulocyte count corrected even further and converted into something known as the reticulocyte production index. This number is based on the fact that normal reticulocytes circulate for about a day. However, in the setting of a marked anemia, reticulocytes can be released prematurely, thus they can live longer and circulate longer. So the RPI corrects for the longer life of reticulocytes in anemia. So in order to calculate a reticulocyte production index, what you do is take that corrected reticulocyte count I showed you on the last slide, and you divide by a maturation time. And this table shows commonly used maturation times. So for a hemoglobin of 15, which is normal, the maturation time is 1. If the hemoglobin falls to 12, it's 1.5. For 8, it's 2. And for 5, it's 2.5. So by using these numbers right here, you can then calculate a reticulocyte production index. And if the RPI is less than 2%, that suggests bone marrow failure as well. Another hallmark of hemolysis is an elevated level of unconjugated or indirect bilirubin. In the GI module, I talk extensively about bilirubin. Here we're going to approach bilirubin from the hematology point of view. So when there's hemolysis, heme is released from hemoglobin and it's metabolized into bilirubin. Initially, it's made into unconjugated bilirubin, which is not water soluble and travels in the plasma bound to albumin. The liver will conjugate bilirubin into a water-soluble form that can go out in the bile. In the setting of hemolysis, there is excess production of unconjugated bilirubin. It overwhelms the liver's capacity to conjugate it and excrete it in the bile, and thus you see an increase in the level of unconjugated or indirect bilirubin. So what this means clinically is that patients with hemolysis can develop jaundice. Jaundice is a yellowish color to the skin, as you can see on this man's face. You can also find it in the sclera of the eyes, as you can see in the zoomed in picture here on the right. You can get this obviously in liver and biliary disease where you cannot excrete bilirubin, but in the setting of hemolysis, you get it because of overproduction of unconjugated bilirubin. There's an increased risk of gallstones among patients with chronic hemolysis, and hemolyzers form a special type of gallstone called pigment stones which contain bilirubin. These are the less common type of gallstone. The much more common type is cholesterol gallstones, and I talk about gallstones in detail in some of the GI modules. Now, I told you before that you can categorize hemolytic disorders based on whether they are due to something intrinsic or extrinsic to the red cell, but you can also categorize hemolytic disorders based on whether they are intravascular or extravascular. So intravascular hemolytic disorders are disorders where the blood cells hemolyze inside the blood vessels. Extravascular hemolysis is hemolysis that occurs outside the blood vessels in the liver or spleen. Both types of hemolysis will cause a normocytic anemia and a high reticulocyte count. What we're just talking about here is the location inside the body where the hemolysis takes place. So let's talk about extravascular hemolysis first. Recall that the liver receives a very large portion of the cardiac output. So if there are lots of severely damaged red blood cells, the liver will remove some of them. However, the much more important organ in terms of extravascular hemolysis is the spleen. And that's because the spleen's job under normal circumstances is to remove damaged red blood cells. So in the setting of a hemolytic disorder, the spleen can start taking more red cells out of circulation than normal. So the spleen's job under normal conditions is to destroy poorly deformable red cells. There are structures inside the spleen called the cords of Billroth. These are vascular channels that end blindly. They're found in the red pulp of the spleen. I'll show you a picture of that in a minute. So under normal circumstances, red cells have to deform to pass through slits in the walls of the cords of Billroth. Only the young and healthy red cells are able to deform in this manner. Old or so-called senescent red cells or damaged red cells get stuck in the cords and they get phagocytosed by macrophages in the spleen. So in the setting of certain hemolytic disorders, especially ones where the shape of the red cell is abnormal, you can see an increased splenic removal of red cells, and that is a form of extravascular hemolysis. Obviously, it's occurring outside of the vasculature. Here's a picture of the spleen from some of our immunology modules. The blood comes in here through the artery. It then percolates through the white pulp and the red pulp. And out here in the red pulp is where you can find those cords of Billroth, which red cells must deform and squeeze through in order to remain in the circulation. When hemolysis occurs inside blood vessels and outside of the spleen, we call that intravascular hemolysis. This commonly occurs due to some form of mechanical trauma that results in narrow blood vessels, and the red blood cells lyse as they try to squeeze through the narrowed vessels. So when this happens in small vessels, it's commonly because a thrombus forms in the small blood vessels, and the red blood cells lyse as they try to negotiate their way around the thrombus. This is sometimes called a microangiopathic hemolytic anemia, and we'll talk about that in some other modules. You can also have intravascular hemolysis in large vessels. One example of this is patients who have a mechanical heart valve. The metal valve can cause lysis of red cells as the blood moves past the mechanical heart valve. Now let's talk about haptoglobin, which is a plasma protein, and you can measure the level of haptoglobin in the serum, and it's useful in the workup and diagnosis of certain hemolytic anemias. Haptoglobin's job is to bind free hemoglobin, and then the haptoglobin-hemoglobin complex will be removed by the liver. So the level of free serum haptoglobin will fall when there's hemolysis and haptoglobin starts binding up all that free hemoglobin. When there is intravascular hemolysis, hemoglobin is released directly into the plasma. This can result in a haptoglobin level that is very low or undetectable. When there's extravascular hemolysis in the spleen, some hemoglobin may still be released from the spleen, so the haptoglobin level can sometimes be mildly low or it may be normal. Now classically, haptoglobin is taught as a marker of intravascular hemolysis only, meaning that the level gets very low when there's intravascular hemolysis. You should know, however, that studies show it can be low in both types. I've listed a review article down here on the bottom of the screen if you want to read more about this, but haptoglobin levels can fall in both intravascular and extravascular hemolysis. However, they get much lower or sometimes even undetectable in intravascular hemolysis, and that should make sense to you because the hemoglobin is being released directly into the plasma where the haptoglobin has to soak it up so it can be excreted by the liver. A few more details of haptoglobin. It's also produced by the liver and it is an acute phase reactant. This means that increased levels can be seen in the setting of inflammation. You can also see decreased levels in the setting of cirrhosis. They don't necessarily indicate hemolysis in that clinical circumstance. There are several urine findings that are typical in patients who have hemolysis, so let's talk about that now. So first of all, you should not see any bilirubin in the urine. That's because the type of bilirubin whose level rises in hemolysis is the unconjugated type, which is not water soluble, and therefore it cannot pass into the urine. If there is intravascular hemolysis, the haptoglobin can become saturated. This will result in free excess hemoglobin that floats around in the plasma. This is called hemoglobinemia. Some of that free excess hemoglobin will be filtered by the kidneys and spill into the urine, and this is called hemoglobinuria. And you can detect hemoglobin in the urine with a urine dipstick test. Now, some of the hemoglobin will be reabsorbed in the proximal tubules where the iron will be converted into ferritin. This will lead to production of a substance called hemosiderin in the tubular cells. The tubular cells slough into the urine over time, and if you spin the urine down to its sediment and stain it with the Prussian blue stain, you can see evidence of hemosiderin. That's called hemosiderinuria, and you can see that in patients who have hemolysis, and that's from iron getting into those tubular cells. Now, you won't often see urine tested for hemosiderin, but you will commonly see urine tested with the urine dipstick test. And as I said before, hemoglobin is part of the urine dipstick. This is a picture of a urine dipstick on the screen. You can see that hemoglobin is one of the components. The dipstick will change colors to indicate the presence of hemoglobin. You should also know that hemoglobin can turn the urine red or brown. This is a picture on the screen of what a urine sample can look like in someone who has hemolysis. Now, just an aside here, but you should be aware that urine can also change to this color in the setting of rhabdomyolysis from muscle breakdown. In that circumstance, it's not the hemoglobin turning the urine dark, it's the myoglobin turning the urine dark. And the dipstick cannot distinguish between hemoglobin and myoglobin, so the dipstick will become abnormal whether there is hemoglobin or myoglobin in the urine. It cannot tell the difference between the two. And that raises another important point. You should be aware if you ever see a patient who has no red cells in the urine but has a positive dipstick for hemoglobin, that patient either has hemolysis or rhabdomyolysis. Often when patients have hemoglobin in the urine by dipstick, they also have red cells. It's because they're bleeding into their urine. However, if you see an absence of red cells but you see evidence of hemoglobin by the dipstick, it means that either the patient has hemolysis or they have rhabdomyolysis. Most of those patients will have dark urine like is shown on the screen here. So this slide summarizes the classic findings of a patient with hemolytic anemia. They will have a normocytic anemia with a normal MCV. The LDH level will be high. There will be a rise in indirect bilirubin, which can lead to jaundice. There will be an increased reticulocyte count, and the haptoglobin level will be low. It will be much lower or undetectable in patients who have intravascular hemolysis. And then on urine testing, you will find evidence of hemoglobin and hemosiderin if the hemolysis is intravascular. The last topic I want to discuss in this module is parvovirus B19. This is a viral infection that is especially dangerous to patients who have chronic hemolytic anemia. Parvovirus B19 is a DNA virus and it replicates in red blood cell progenitor cells and it leads to decreased erythropoiesis. Now, in healthy patients who are infected with parvovirus B19, the red blood cell production returns to normal in 10 to 14 days. Usually they have a very mild anemia or no anemia at all, and this virus commonly infects school-age children. They often don't have a red blood cell count monitored. They may look a little pale for a day or so, but then they feel better and they have no serious consequences. However, patients with chronic hemolysis have chronically increased red blood cell turnover, and they depend on their bone marrow to crank out red blood cells in order for them to avoid a severe anemia. So in this circumstance, the lack of erythropoiesis in the setting of a B19 infection can lead to severe anemia, and these patients can develop pallor, weakness, and lethargy, all signs and symptoms of a marked anemia. This is sometimes referred to as an aplastic crisis in patients with chronic hemolysis. B19 is classically taught as complicating sickle cell anemia, but it can also complicate hereditary spherocytosis or beta thalassemia major. We'll talk about all these conditions in other modules, but for our purposes here, just know that patients with these conditions have chronic hemolysis and they depend on their bone marrow to maintain a reasonable red blood cell count. If they become infected, they can get a very serious anemia. And the classic scenario is for a patient with one of these chronic hemolytic conditions to present with a worsening anemia and a low corrected reticulocyte count. This is one of those circumstances where correcting the reticulocyte count is very important because the anemia can appear to just be a worsening of the hemolysis from one of these conditions. However, when you correct the reticulocyte count, you will find that it is inappropriately low. That indicates that the bone marrow is the source of the problem. The patient is underproducing red cells, and one of the reasons that can happen is because of infection with parvovirus B19. The last topic for this module is back and abdominal pain. These are symptoms that are seen in some hemolytic syndromes. For one thing, abdominal pain can occur if splenomegaly is a prominent feature of any hemolytic disorder. In addition, back and abdominal pain can occur due to smooth muscle spasm in the abdomen and back area. This is thought to result from low levels of nitric oxide. You may know that nitric oxide is a smooth muscle relaxant, so if the level gets low, that can lead to smooth muscle spasm in the back and abdomen. It turns out that nitric oxide is scavenged by free hemoglobin, so if free hemoglobin is a prominent component of a hemolytic disorder, that can lead to low levels of nitric oxide, which can trigger smooth muscle spasm. And this is common in some hemolytic disorders, especially patients who have paroxysmal nocturnal hemoglobinuria or G6PD deficiency. In both of these disorders, patients have episodes of increased hemolysis, and during those episodes, they often complain of back and abdominal pain. And that concludes our module on basics of hemolysis.